All right, hello everyone. My name is Sean. Thanks for joining today's session. I'm part of the Knowledge Mobilization Hub of the C10 Plus. I'm excited to welcome you to today's webinar, where we'll hear from the team leading the Living with HIV and Chronic Pain in Canada study, which is supported in part by the CTN and led by Dr. Francisco Abanez Carrasco. So to begin, I'd just like to acknowledge that I'm joining from unceded Coast Salish territory in Vancouver, and that C10 work takes place across many traditional unceded lands across Canada. So now I'll just pass it to Sarmitha Sivakumaran, who's the research coordinator for this study, and she'll introduce our speakers and moderate the session.
Thanks, Sean, and thank you everyone for attending today's webinar. It's my pleasure to introduce our speakers, Kath and Darren. Kath Webster has been living with HIV for over 30 years and has been very involved in the HIV community in many capacities ever since. She has also dealt with chronic pain for over a decade. Kath lives in Coast Salish territory on Salt Spring Island, British Columbia, and Darren Lauscher has been living with HIV for over 45 years and has been very involved in the HIV community in many capacities ever since the mid-90s. He has dealt with chronic pain for over a decade, primarily neuropathy. He also lives in the Coast Salish territory in downtown Vancouver. Now, without further ado, I'll hand things over to Kath and Darren, who will be taking us through today's presentation. Thanks both for joining us, and over to you.
Thanks, Sarmitha, and hello, everybody. Thanks for joining us today. Our study is titled Living with HIV and Chronic Pain in Canada, a community-based, mixed methods, multi-sectoral, interdisciplinary, and intersectional study. And the project is funded by the Canadian Institute of Health Research with financial support from CTN, Canadian Trials Network, and approved by the University of Toronto Research Ethics Board. I also want to add to Sean's land acknowledgement by saying we recognize our research team is situated across many different lands, and today we are acknowledging that Sean, Darren, and I are presenting from the traditional unceded territories of Coast Salish peoples. And this land has been home to Indigenous peoples for thousands of years and continues to be a place of gathering, knowledge, and community. These lands are home to many Indigenous peoples from across Turtle Island. We are grateful for the opportunity to live, learn, work, and share knowledge on this land. So we have just a couple of slides to introduce our topic and provide a little background. So first slide, so looking at our topic is HIV and chronic pain. So to make sure everyone's on the same page, HIV, or human immunodeficiency virus, is a virus that attacks the immune system, and approximately 60,000 people in Canada are living with HIV. ARV therapy has transformed HIV into a manageable chronic condition for many. However, even with treatment, people living with HIV continue to face ongoing health, social, and psychosocial challenges. Now, looking at chronic pain, our definition we're using in this study is that it's pain that persists or recurs for more than 3 months. And unlike acute pain, chronic pain can continue beyond normal healing time. And chronic pain affects daily functioning, quality of life, and overall well-being. Okay, moving on to the effects of HIV and chronic pain combined. The effects can be understood across biological, psychological, and social domains. So biologically speaking, this can cause ongoing physical discomfort, of course, fatigue, reduced energy, disrupted sleep, and overall reduced physical functioning. Psychological impacts, anxiety and depression, stress, difficulty concentrating, and the added burden of managing both HIV and chronic pain. In terms of social impacts, reduced participation in work and daily activities. It can be a real strain on relationships. Some people withdraw from community and social life, and basically your world can become very small very quickly when you're experiencing a lot of pain. Okay, we're going to look at the study objectives now. The first objective was to describe the nature and extent of chronic pain among adults living with HIV in Canada, by exploring the intensity, variability, and the impact on daily life. Secondly, we want to identify the needs of adults living with both HIV and chronic pain. And this includes understanding what forms of support, resources, and care are most helpful, and identifying gaps in current healthcare and support systems. And this will hopefully provide a foundation for improving care and developing more responsive strategies. All right, we're going to now look at methodology. So methodology, we're a mixed method study design. We have community-based and a participant-centered approach. First, participants completed an online survey that was available in English and French. And this survey included some structured questions, some open-ended questions, and opportunities to describe pain and its impact in their own words, which was an important part of it. Open-ended responses were analyzed using AI-assisted qualitative analysis. And this helped identify major patterns and themes, which were then used to develop statements for the Q sorting sessions. And there'll be more on that in a minute. But the goal overall was to ensure that participant voices always remained central throughout the study. Okay, moving on to next slide. So these are some of the standardized scales that we use to capture participants' experiences of pain from a holistic perspective. We used these scales to evaluate substance use, anxiety and depression symptoms, pain severity, pain-related self-efficacy, which is just basically your confidence in your ability to manage your day-to-day life despite the pain, and pain acceptance. And the purpose of including these scales was to provide a comprehensive view of the biological, psychological, and functional aspects of chronic pain. By combining these measures with the open-ended survey responses and the Q sorting data, we were able to integrate both quantitative and qualitative insights into the participants' lived experiences. Next. Yes, so the Q sorting. Oh, is there a question or no?
No, that's just me, Kath.
Okay.
Go ahead.
Yeah, this is my slide, I believe. You're next after this. The Q sorting sessions, this was, well, I really enjoyed this part of the study very much. It's a method used to examine people's opinions, priorities, and subjective experiences in a structured way. So participants were given a set of statements, and those are the statements that came from the AI data collection. They summed up what they heard from all of the open-ended questions and created these statements. And then we had participants, the ones I was involved were in person, and people ranked the statements according to how much each statement resonates with them. So on this pyramid-shaped grid, they would put the statements that resonated the most on one side and the ones that resonate the least on the other side, with the neutral statements would be in the middle. And in this study, we adapted the Q sorting to also include a qualitative discussion. So after they sorted and put up all the statements in their places where they wanted them, the participants then explained why they ranked certain statements highest and lowest and how they made these decisions. And this helped capture common patterns as well as individual perspectives. And then we did use protected AI model to analyze these discussions and identify the key themes. Now over to Darren to talk about some survey results.
Thank you, Kath, and apologies. I'm just, a keener, wide awake, too much coffee. So moving us along, we will briefly summarize some of the results from our survey. from both, including both French and English in those results. And want to highlight the participants' demographics, their health conditions, and support needs, and provide some context for understanding the experience of adults living with HIV and chronic pain. And next slide. So as you can see, we have biological sex and gender, and we felt it was important to ask both those questions. And you can see from the responses, predominantly male, 68.1%, and female, 31.9% in the biological sex at birth, and then gender. Most important to include this as well. And now you can see it sort of parse out. Still heavy with people identifying as a man at 60.1% and identifying as woman at 31.5%. But then there's the nuances of other, which is really, really important for us in research to be capturing in that bigger picture, to include all of humanity. I would put it out there is that who makes up our communities. So moving on to race and ethnicity, we wanted to capture as broad a spectrum of the Canadian landscape. Not always easy, but being an online survey tool lends itself to that broader spectrum capture. But again, you can see 41.1% is white, 25.8% is Black, 13.1% is Indigenous, 9.8% for those who identify as East Asian, Southeast Asian, and Latino as 6.8%. And then smaller, that would fall into the Arab West Asian piece, which again, I believe is very important for us in research to be capturing all who make up our Canadian population in that bigger picture. And moving on to employment status. Now this is interesting amongst, as we actually were figuring out the questions to be asking, what was important to some of us in that discussion as we were developing the survey questions. And it was taking into account the volunteering aspect. It was taking into unemployment, but also seeking work or working under the table. Always interesting questions, always a bit of heightened fear of people answering that question, realizing that they potentially are doing, quote, illegal work and Mr. Taxman would like their cut, or disability doesn't want you to make any money or very little bit of money in that bigger picture. So some really good questions and some strong answers, and not unexpected in that bigger picture. And moving on to our age demographics. So as you can see, we had a broad spectrum of age group and year of diagnosis, which was really important as well in that bigger picture. We quite often ask age, but we don't ask diagnosis year. And that lends to different responses from people because their spectrum of lived experience is going to be vastly different in that bigger picture. And you may have pain in the early days, and then your medication regime changes and that pain goes away. And then it changes again and it comes back. So there's many, many pieces that are at play here that need further exploring. And moving on. Receiving HIV care. I find this number, I'm really happy to see 94% of our people are receiving care, but that 6% not receiving care, that's worrisome in that bigger picture of what's happening in their life their ability to access the healthcare systems, all of those pieces. And it may be a range of factors, including the barriers to access, prior experience within the system, individual circumstances and preferences. It highlights that engagement in care is not uniform and underscores the importance of understanding and addressing the diverse factors that influence access and continuity of care. And moving on. Next page, please. Health conditions. As you can see, conditions that you would expect to see for those living with pain, for those that are providing health care, things that your clients would potentially talk to you about. Nothing totally unexpected. However, over half the participants reported a mental health condition. And that, combined with trouble sleeping, and then adding in gastrointestinal pieces, those are significant numbers when combined, along with the chronic pain in soft tissue or joint. These numbers illustrate the complex, multidimensional health challenges faced by adults living with HIV and chronic pain. They're not just dealing with pain in isolation. Physical, psychological, and social factors are often intertwined in all of this. Next page, please. So our health conditions. Turning to mental health, we see significant levels of anxiety, depression among participants. On the CAD-7 scale, about 38% of participants fell into the severe anxiety range. While on the PHQ-8 scale, approximately 31% reported mild depression. These findings reinforce that psychological well-being is closely linked to chronic pain in this population and must be considered in holistic care planning. When we look at accessing services, family support was the most frequently reported resource, with 55% of participants noting that they relied on family. Physiotherapists and community-based organizations were each reported by around 28% of the population. These findings suggest that people rely on a combination of formal and informal supports to manage chronic pain and related challenges. It's important to note that these numbers represent the common conditions and supports reported rather than an exhaustive list, but they provide a clear snapshot of the key areas affecting the daily lives of people living with HIV and chronic pain. And moving to our survey, our qualitative responses. A bit of a busy slide. Lots of pretty colors, and now as an older person with eyesight issues, some of those colors are too damn light. Going forward for the aging population, we'll need to use darker colors. Going on, this figures highlights the range of patient messages and priorities that emerge from the qualitative survey responses. Participants expressed a mix of appreciation and concern in their interactions with the healthcare system. On one hand, there was clear gratitude for providers' dedication and the desire for empathy and understanding, emphasizing the importance of being heard and taken seriously. At the same time, participants identified ongoing challenges, including frustration with judgment and delays in care, as well as concerns around accessibility, particular financial barriers and wait times. There was also a strong emphasis on improving pain care, with participants seeking better pain management options and looking towards future strategies, including more holistic and sustainable approaches. So together, these themes reflect both the strengths of current care and the areas where meaningful improvements are needed, reinforcing the importance of patient-centered responses approaches. And back to Kath.
Okay, now we're going to look at a little more about the Q sorting sessions. These sessions were held in multiple locations across Canada. Next slide. Yeah, there we go. Vancouver had 3 sessions. Toronto had 2. Charlottetown PEI had a session. And online there was 1 session. And that really helps people who could not attend in person to have an online one. And looking ahead, we have Winnipeg, Montreal, and 2 more online sessions. So it did help improve accessibility and inclusion by having such a variety of sessions, both online and in person. Next slide. Looking at the participants who came, we had 76, 74 of those were people with lived experience of both HIV and chronic pain. And then we had 2 service providers who added additional context from a care and systems perspective. On average, participants were in their mid-50s, the range being 30 to 60-year-olds. So this captures both midlife and older adult perspectives. Now we'll look at some key themes. So stigma, judgment, and anticipated discrimination was a big one. Participants described being judged, especially when discussing pain medication or care needs. Some felt they were assumed to be drug seeking rather than being seen as just people living with pain. And many people described feeling that they had to prove themselves innocent before being taken seriously. Stigma was not only based on current encounters, but was shaped by past experiences. So that was the anticipated discrimination piece. And anticipating judgment created an ongoing emotional burden. And some participants described carrying a kind of a protective armor into healthcare interactions. And for long-term survivors of HIV, histories of loss, neglect, and marginalization really intensified this burden. Stigma also influenced communication with providers, self-advocacy, emotional well-being, and willingness overall to even engage in care. So you can see a couple of quotes that came directly from the sessions. As soon as you identify what you might be seeking by naming a medication, you're never getting it. They assume you might be a drug addict. We bring it. It's a memory, like armor underneath now, so we're ready if they judge us. And then barriers to healthcare. Posters are everywhere. Don't insult staff. It makes a negative environment instead of welcoming patients. So those were some of the key themes. And Darren has more key themes. Oh, actually, no, I have a few more here. Participants also described healthcare settings as not always feeling welcoming or safe. And even subtle things like restrictive policies and like the warning signs I just mentioned, that could heighten anxiety. But if they could have supportive, respectful, inclusive clinic spaces, it made it easier for people to discuss pain and HIV openly. Also, I want to mention geography, because people in rural or smaller communities often had limited access to providers who are knowledgeable about HIV and chronic pain. Virtual care could improve access, but participants noted it could not fully replace the trust and reassurance of an in-person connection. And so these findings show that healthcare access is not only about whether services exist, it's about whether the care feels safe, respectful, and responsive. Okay, Darren will continue with some more key themes.
Thanks, Kath. So medical distress. We don't go to doctors as much anymore because they make us feel less. I tried to stay calm when I talk to the doctors, but can I really show them my pain? Most medications come with side effects. So that medical distress piece, that how do we eliminate it? How do we make this a collaborative, patient-centered care, all of those pieces of good care? that we all hope and wish for. So that distrust plays an important role here that needs to be examined further. And as you can see, it's been a major theme in our study, reflecting the complex and sometimes strained relationships between participants and healthcare providers. The distrust is often tied to the challenges of communicating pain in ways that are recognized and validated by the medical system. As Kath has pointed out, you can go into an office and you're in pain, but if it's not visible, how do you describe it? How do you get it across to your provider that you're in pain? And so it's inherently nuanced, it's subjective, it's difficult to quantify using standard clinical language. One participant expressed frustration that professional terminology, such as shooting or burning pain, did not capture their lived experience, and that simply saying it's painful often left to their pain being minimized. Another participant noted that struggles to translate feelings into words that fit the checklist of acceptable pain descriptors used in clinical encounters. So analytically, this difficulty in communication contributes directly to distrust. When patients feel their experiences are not understood or respected, it reinforces a sense that the system is not designed for them. Participants emphasize that lived experience matters. Providers who do not have personal experience with chronic pain or with HIV may struggle to grasp the depth, complexity, and day-to-day impact of these conditions. One participant observed that while there are providers who care deeply, the lack of shared experience can make understanding difficult, which can leave patients feeling unheard or dismissed. Another dimension that contributes to distrust is the lack of age-specific care. Participants in middle and older age groups express that much of the available guidance, resources, and interventions are oriented towards younger populations, leaving them feel forgotten or overlooked. One participant noted that information is often geared towards a different generation, highlighting a structural gap in care that reinforces skepticism about whether providers can adequately address their needs. Taken together, these factors, difficulty communicating pain, the absence of shared lived experience among providers, and gaps in age-specific care, creating a landscape where distrust is both understandable and persuasive. It is relational, grounded in past interactions and historical experiences, and structural, reflecting gaps in how care is designed and delivered. Medication hesitancy. Most medications come with side effects. Closely linked to all of this medical distrust is the medication hesitancy, which emerged as another prominent theme. Participants expressed deep ambivalence about using medication to manage pain, reflecting both practical concerns and broader relational dynamics with healthcare providers. The slide highlights two illustrative quotes. Most medications come with side effects, and the underlying sense of caution and vigilance that patients carry when considering pharmaceutical interventions. Participants describe multiple factors shaping their hesitancy. One was fearful of side effects, informed by both personal experience and observation of others. A participant spoke about a relative who experienced complications from medication, highlighting the way these experiences shape trust and decision-making. Another participant referenced opioid use, noting that they could be used safely with respect, reflecting that adherence and engagement are strongly influenced by how care is framed, discussed, and negotiated with patients. These reflections show that hesitancy is not a rejection of care, but a careful, thoughtful weighing of potential benefits and harms grounded in lived experience. Underlying this hesitancy is a broader challenge in how pain and medications are communicated. Participants describe feeling that biomedical language and standard prescribed practices often feel disconnected from their lived experience, leading to frustration and caution. Participants also express that alternative approaches such as self-management strategies or non-pharmacological interventions are not always recognized or supported by providers. This contributes to a sense that their expertise and agency are undervalued. These challenges of communicating pain intersect closely with medication hesitancy, as we've already spoke, because pain is difficult to describe in ways that are accepted by providers. Participants often worry that their needs may be misunderstood or that inappropriate medications may be prescribed. This adds another layer to distress. If a patient cannot fully articulate their pain in clinical terms, they may fear being dismissed, over-medicated, or subjected to assumptions about drug seeking. In this way, distrust and hesitancy are mutually reinforced. Patients are cautious because of prior negative experiences, and the system can inadvertently reinforce that caution when pain is poorly understood or communication is constrained. Analytically, the theme of medication hesitancy illustrates the importance of relational and context-sensitive care. Participants are not simply resisting treatment, they are critically evaluating options based on their prior experiences, anticipating side effects, and their own strategies for managing health. Their ambivalence is a rational response to a system that does not always integrate lived experience into decision-making. It also reflects a desire for autonomy and respect in managing complex chronic conditions. Finally, the narratives around both distrust and hesitancy underscore the importance of person-centered care that validates patient expertise and experience. Participants highlighted that trust is earned when providers listen, take the time to understand the patient's lived context, and acknowledge uncertainties around treatment. Conversely, when interactions feel dismissive, judgmental, or overly prescriptive, patients may disengage. Limited disclosure or rely on self-directed strategies. In this way, medical distrust and medication hesitancy are not isolated phenomena. They are deeply interconnected, shaped by communication challenges, relational dynamics, and structural factors within healthcare. So in conclusion, pain is complex and difficult to communicate. Participants describe their pain as diffuse, unpredictable, and often challenging to put into words. Standard clinical descriptors like sharp, burning, or shooting often do not capture the full depth of their experience. This complexity can make it difficult for patients to convey their needs and for providers to fully understand them, underscoring the importance of listening carefully and validating each individual experience. Second, there's the care gap that exists. Many participants shared that providers rarely asked in-depth questions about their pain, and when guidance is available, it may be limited or unclear. Access to care often depends on how pain was presented or explained, leaving participants feeling that they had to justify their experiences in order to be heard. These gaps point to opportunities to enhance provider training, improve clinical guidance, and create systems that are more responsive to nuanced realities of living with chronic pain and HIV. Finally, self-management is common and highly individualized. In response to the limitations of available care, participants have developed personal strategies to manage their pain. These include pacing daily activities, using cannabis or other complementary approaches, engaging in movement or exercise routines, and sometimes self-regulating medications. These strategies reflect both resilience and lived experience as people carefully balance the potential benefits of medication with concerns about side effects, dependence, and trust in the healthcare systems. Taken together, these conditions emphasize that supporting adults living with HIV and chronic pain requires a holistic, person-centered approach. It is not solely a biomedical challenge, but one that intersects with social, emotional, and systemic factors. Recognizing and valuing patients' lived experience, addressing gaps in care, and supporting self-directed strategies where appropriate are essential to improving both health outcomes and quality of your life. And our next steps. At first, we conclude our findings point to clear directions for improving care for adults living with HIV chronic pain. First, we need to advance equitable patient-centered care. This means creating systems and practices that recognize the diversity of experience and ensure every person's pain is taken seriously. Without assumptions or biases, patient-centered care is not just about clinical interventions, it's about listening, validating lived experience, and creating environments where people feel safe, respected, and empowered to engage with their care. Second, it's essential to strengthen provider guidance. Many participants describe uncertainty and gaps in their care they receive, reflecting the need for improved training and clinical tools. By equipping providers with evidence-informed guidance that addresses both the complexities of chronic pain and the unique needs of people living with HIV, we can ensure care is consistent, equitable, and responsive. And third, we must recognize and value lived experience. Participants demonstrate deep knowledge about managing their own pain, whether through practice, pacing, movement, cannabis, or self-regulated medications. Integrating patients' insights into care planning not only improves outcomes, but also affirms their expertise, dignity, and agency in managing their health. And finally, we should support safe, evidence-informed options. Providing access to reliable resources and thoughtfully integrating patient-led strategies alongside biomedical care allows individuals to make informed choice, balancing safety, effectiveness, and personal preferences. This approach strengthens their trust and collaboration between patients and providers. In short, advancing care for adults living with HIV and chronic pain requires a shift in perspectives, from treating symptoms in isolation to centering lived experience, respecting expertise, and creating systems that are inclusive, supportive, and equitable. And as we close, it's important to remember solutions are not only in clinical interventions, they are in partnerships, respect, and the recognition that people living with this experience are the true experts in their own lives. Our responsibility is to listen, learn, and act in ways that honor their expertise. Thank you. And now I just want to say thank you to our greater team that make up this project, the brilliance of all the peers and the brilliance of the academics who have taught me many valuable things, many new tools of measurement that I had no idea about, and to our fearless leadership under Francisco and Samita. Thank you. And now I open the floor to questions, and if you would like to raise your hand and or put it into the chat bar. Thank you.
Emily.
Emily.
Oh, thanks, Darren and Kat. It was awesome to hear you both present. I had a question. Knowing that there was two healthcare providers a part of this study, just curious about what if you know what they brought to the conversation in terms of themes around particularly like medical distrust and medical hesitancy. Like, what were their views or what was their narrative around those topics, if any?
Great question. And I'm going to turn that over to Francisco because I believe he did that session.
Thank you. Before I respond to this, Emily, there was a fatal gap in what they presented, and is that peer researchers have been at the heart of this, and I have the honor for real to work with 6 amazing peer researchers. So they forgot that, but we lost one peer researcher, Colleen Price, who was really the agitator, the original kind of to do all of this. So that must be recognized as well. Back to what the clinicians said, we still have a couple of clinicians meetings online that we have to complete. But clinicians told us 2 things. One is that they're aware that they don't ask the right questions. And in a way, they're constrained by the system, not to us, just like has happened with in other studies when asking about the use of drugs or neurocognitive problems. It's kind of collaborative, I don't know, agreed silence about these things, partly because they don't have a protocol and they need to take care of kind of the immediate stuff that is more bodily I forgot the word, that is concentrated on the body, that the first line of help. Um, and the second thing they said, I forgot because I'm at that kind of age. But I'll think about it and I'll respond. So there were two really interesting things. One of them was like, we don't ask the right questions. And the other, I think, is don't really have much we can do. Um, I think this needs to be interpreted in the larger context of Canadian healthcare and what is going on now. We did talk to, for example, folks who are 70 plus years old in some provinces whose care, because we're talking about care, whose care is only going to a walk-in clinic where they get their prescriptions signed for the next batch of medications. That is the care they receive. So I'm hoping we're not thinking like, oh, someone talks with them and they're referred to other things. That's the extent of the care. I hope that, Emily, I hope that responds a little bit to what you were asking.
Yeah, that's great. Thank you.
Denise.
Yeah, thank you. First of all, I really like the slides and they were very easy to read, and thank you for that. I just find that it was so nicely laid out. So thank you for doing that. Uh, the second thing when you were talking about stigma and when people go in for pain medication and it's automatic, they're assumed to be a drug taker or whatever. Did you have kind of a placebo study on that? Because I know I've been into my GP with my husband who's not HIV positive, and he has wanted a medication for his illness that he has, which is not HIV, and it's automatically assumed he could be a drug taker. So they're not giving, they're thinking twice before they're giving him that medication. So is this something that is focused on people with HIV, or is it a general distrust of anybody who's going in now that they could be a drug taker?
You want me to tackle that? Sorry, I don't mean to. It's okay. It's okay. So no, this is a very good question, and it's complex. I think one thing we did in order to create more of a balance from the survey, which you saw was mostly men, is most of the Q sorting, or a great deal of it, has been done with women of color and Indigenous women, for whom, and this is where race enters the picture, for whom it's assumed before they get into the office that they want to get something, right? There's already an ulterior motive for what they want to get. So I think it's crossed by ethno-racialized identities as well. I don't know if it's general in Canada. That we cannot talk about that from this sample, but definitely from this study and other studies I've done with Dr. Kelly O'Brien and Dr. Rachel Landy, we know that women in particular are less believed than men, and that comes also with the ethno-racial component, that if you're an Indigenous women told us a lot of things. They laughed at it when we asked the question. They said, of course they don't believe us. So that's a picture we can paint with this sample. And great to see you, by the way.
We have a question. Shelley, we'll get to you. And the question is, thanks for the information. I'm just curious, with 6% folks not using the medications, any particular reasons? We know some barriers, but I'm more curious if someone, it's more personal decisions don't take it. Francisco.
Yeah, I don't think we really asked for that nuance, right? And sometimes, and good to see you, Aleja. Sometimes we don't ask so much about the small numbers because then we tend to speculate more. So that's, for example, we would do a disservice if we focused only on transgender people because our sample is very small. So overall, we don't know why that 6% doesn't take medications. We know from the majority of our sample that people try things, right? They microdose, for example, fentanyl or cannabis or meditation. So they go into that kind of body-mind practices. But unfortunately, I cannot give you an answer for that particular one, Aleja.
Shelley.
Good morning. Really, really great to see so many folks here today for this presentation. I have a question regarding the recruitment strategy for the Canada-wide, because I see that you're doing such a broad, I mean, I haven't seen a study that's reaching out to the communities, as many communities as you are. So I'm curious what your recruitment strategies are and how what maybe some of the key takeaways for other research projects looking at the barriers to the most marginalized, and how do you deal with the technological issues like the access to internet, the access to be able to participate, and what that looks like, and what is your I see the cohort for this is 78. What's the ultimate cohort size going to be? Because it sounds like it could be upwards of 500, 700 people once you're said and done.
Great question, Francisco, please.
Okay. Shelley, always good to see you. I hope you're still dancing.
I am.
And good, because we all need movement, we all need exercise. So our recruitment strategy has been, and in this sense, I'm going to be very pro HIV positive. I mean, the thick of us, the peers and myself are people living with HIV. We've established networks across the country for a long time. So one example, when we wanted to talk to women living with HIV in Toronto, we went to an agency where we have friends, and then we were super happy because they said, oh, we have 30 Black women, most of them immigrants, most of them from African, Caribbean regions, who will talk with you. And so that's been the way. It's really word of mouth. We never intended to form a cohort. We said to CIHR, and they believed us, thankfully, that we would do only 5 sessions. But thanks to Sarmitha Sivakumaran, who's exceptional in her work, we're doing many more, and we're happy because that helped us balance the number of women. So we focused a lot on women because we didn't have that many women in the survey. And of course, there must be a little bit of overlap between the survey answers and the people we talked with in person. We didn't ask them that question, whether they had completed the survey, but we're very happy we're talking with more women. Shelley, does that answer your question?
Yeah, I guess in the bigger picture, when you're looking at, sort of this, well, I have many questions, but I think when you're looking at trying to get the voices, sort of the unknown, the lost to care, follow up the lost care voices, how do we better strategize the barriers that they face? Like, because I think a lot for a lot, it comes down to technology in many of the rural settings, right? So we know we can get the existing infrastructure that's there. We can utilize that. We can maximize that. But where do you see the gaps in reaching those that we have difficulties reaching? And because this is all virtual, which is a bonus, but it also has, which I'm learning as an early researcher, has its barriers, right? And looking at all of these, so I guess you have answered my question, Francisco. I guess I'm throwing it out there to everyone to consider those barriers, because I think they, for all of our conversations, we keep running up against them. And I keep trying to strategize in my mind. Is it asking for more funding to ensure that we can have outreach so that we can reach those people, so that we can do, we go to those centers, whether they're in the north or in the interior of any province or in places where there's no urban center within a 200, 300-mile radius. So anyways, I'm just throwing it out there because I think there are voices we're missing, including the Yukon. That even though there's not that many, and as Aleja eloquently pointed out, 6% is 6% of those not on medications, but there's a bigger picture there of voices that are lost. And I just throw it out to all to consider how we can do better at capturing those. Thank you so much, Francisco. It's lovely to see you. I hope to see you at CLAR.
Thank you. I will be there.
Yeah.
Thank you. You're so right. I mean, most of them have been in person. So and to do community-based research properly and in person, let me be crass, and I'm echoing you, Shelley. You need money. You need people to take planes and all those things to get to places where people are. We used to do that in BC, and now people think, oh, online has come to solve everything and make it cheap. It is a problem.
It's expensive. And I think the message is ask for the money. Ask for the money. CBR is not cheap. Ask for the money. Put it in your grant. Thank you.
Yeah.
Thank you.
And just to add to that question, Shelley, and the answer is we're learning from our counterparts who are doing research online and learning from their mistakes. Learning that there are a lot of evil people out there who are just trying to scam systems for money. And so learning those safeguards, which then also adds layers to the process of using technology. That's something that we've learned along the way. Devalia.
Yeah, I just did the digital detriments of health conversation. And yes, it is a challenge for sure. When I did the community-based research center study on the long-acting injectable, we had to facilitate the use of a computer at the ASO because, again, participants don't have access to technology. And some of those marginalized groups were able to participate. It's not easy because it's using a third party and trying to coordinate everybody's times, but it's a matter of trying to access the people who can't do it. And there are some people that are illiterate, and there's people that don't come very often. So it is definitely a challenge to access that. I know I worked really hard because I'm a peer and I wanted to involve my peers. So I think it's kind of taking the onus of a peer researcher, which has to reach out to those individuals one-on-one. I know with the SHAPE study, they came to the ASO and were able to recruit people when they were already there and bring them in, which worked. But there's also about how do you spread that information? And for me, it's word of mouth, because otherwise people aren't online accessing to find a study. And so even this study I didn't know about, and you're mentioning how you're still recruiting for an online. Is that coming up? Would I be able to participate in that? Is there information for that? I mean, I get emails, but I wasn't getting emails about this, and being as involved as much as I possibly can, then I'm also able to recruit. The island is very isolated with being able to participate in studies. There's a lot more in the greater Vancouver area. And so I'm kind of the representative for the island because that's my mission, is to have the island involved, and specifically Victoria, because we don't have anything for HIV here, period. And so the more that we can have that, I think the better representation you're going to have in the study as well.
And, thank you for this. And let's have our people talk to your people. Our people, of course, is Sarmita and I, and we can do that. Most of all of the Q sorting with people and with HIV, and chronic pain have been done in person. The clinicians were treating them differently because it's harder to get them online. So there's been only one mix of people with HIV in French and clinicians in French, but we still have to make a couple more. But for real, if you want us, and we can think of going. We're not super rich, but we made very judicious use of our taxpayers' funds. So happy to do that.
Thank you.
Sean.
Thanks, Aaron, and thanks to the team for this great presentation. I certainly learned a lot. First, I just want to plug this great article. It's an interview of Darren that Laura from our team wrote and describes the study and lots of the stuff that we heard today. But from what we did hear today, it's clear that clinicians have a lot to learn from this study. So I'm just wondering if you guys can describe, your plans for connecting with clinicians and uptake and kind of changing practice from that direction.
Oh, I feel bad about it. Well, anyway, here we go. So we have less plans to connect with physicians because I feel that given the context of what we've done and the interpretation of what we've done, they're kind of a trapped audience. They don't have a lot of room to move. However, we believe that we have room to move in the sense that we can provide people with patient guides and those kinds of elements. So we're doing the same thing with the Neurocognitive Project and with HIV in Motion, the rehab and physical exercise project. We believe that increasing the voice, and by that I don't mean anything symbolic, but real, practical voice of people that can breach the subject with healthcare providers, we have a better chance than moving the healthcare system that overall, and we might discuss this later, is not moving really in our direction overall, right? We're spending money in wars and other kinds of stuff, in my view, but that's aside. So we're aiming our knowledge mobilization. We're doing it today. We sent an infographic, for example, to PEI because they requested us to get an idea of what we got out of those sessions. So that is where we're and this. Thank you, Sean and CTM Plus. This is also another venue for reaching out to people, activists, leaders in the community.
That's great.
I would add,
So,
go
Darren,
ahead.
I was just going to add that we are recording, as you can see today, and we'll be putting it on our YouTube as well. So everyone who registered for today will get that recording, and then we encourage you to share it far and wide as well.
Yeah.
Sorry.
I would add to Francisco's piece that many of us that are involved with the project and other projects similar, we also spend time in front of academic students, our future healthcare providers. And this is where we can take research and bring it to the classroom and not wait for 10 to 15 years for it to appear in a textbook. We can bring it and explain why the importance. So it's that collaborative process. We know we have silos within the healthcare system. And as Francisco says, it takes forever and a day to move the dial. Let's go around the dial, make our own watch. Denise.
Thanks, Darren. My one suggestion would be to put it in the KD magazine that's next coming out, because that does reach a lot of clinicians, and so I would suggest that, or even they put a lot on LinkedIn as well, so it might be something worth considering.
Thank you. Any further questions, comments? We've just passed the top of the hour.
Thank you to everyone, and again, thank you to the peer researchers. I've been working as a peer researcher and with peer researchers long before I became whatever it is I'm now. And if it wasn't for us, the field would not move. So thank you, all of you.